Well, hello, everyone. Thank you for joining us here at Stanford Medicine for our Building a Culture of Health Equity monthly lecture series. My name is Terrence Mays, and I serve as the Associate Dean for Equity and Strategic Initiatives, as well as the Executive Director of the Commission on Justice and Equity here at Stanford Medicine. The Building a Culture of Health Equity program is organized by Stanford Medicine's Office of Continuing Medical Education, the Stanford Medicine Health Equity Action Leadership, or HeLa Network, and the Stanford Medicine Reach Initiative, Racial Equity to Advance a Community of Health. And the lecture series highlights education, research, and innovation that work toward ensuring all individuals receive equal priority and the highest level of care, so that together we are building a culture of health equity across our nation. We are grateful once again to have attendees from all over the country, and we are thrilled to have an incredible panel of health equity leaders and change makers here to speak with us today, and I'll introduce them in just a moment. But first, a little housekeeping. We invite you to use the Q&A button on your Zoom tool if you would like to submit a question for our speakers. Please feel free to add your question at any point during the lecture, and we'll do our best to get to all of them during the Q&A segment, really in the order in which they come in. Also, if you experience any technical issues, please use the chat function and someone on our support team will assist you. So next, please mark your calendars for our next monthly lecture series. We'll announce the speaker very soon, but the next monthly lecture is scheduled for August 18th at 11 a.m. Pacific Standard Time. So without further ado, it is my pleasure, my distinct pleasure, to introduce three amazing colleagues and our speakers for today's session. Dr. Michelle Williams is the Executive Director of Research and Health Equity at Stanford Healthcare, and also Clinical Assistant Professor in the Division of Primary Care, Population Health, in the Department of Medicine. A long-standing health policy and health system scientist, Dr. Williams has advanced health equity research, catalyzed clinical and systems transformation, and empowered stakeholders during her esteemed tenure at complex healthcare organizations and academic institutions. Her distinguished professional career has spanned Stanford Healthcare, where we are grateful that she is now in the Stanford School of Medicine, as well as the Alameda Health System's Highland General Hospital in Oakland. Also, with over 30 years of experience previously at Kaiser Permanente, Dr. Williams had several roles, including National Director of Technology Research Innovation and Chief Nurse Executive at Kaiser Richmond Medical Center. Dr. Williams is the recipient of several health equity and diversity, inclusion, and equity grant awards, a co-author of numerous published articles on these subjects, a co-investigator or principal investigator on several clinical studies, and will soon launch a health equity and DEI grant award to support faculty and clinical staff-led research across Stanford Medicine. Recently, Dr. Williams became the founding president of the 2021 inaugural Stanford Medicine Black Nurses Association chapter of the National Black Nurses Association. Next, we have Dr. Kim Van Eyck. Dr. Van Eyck is the Director of Health Equity Research Division in the Office of Research Patient Care Services here at Stanford Healthcare. She has a broad portfolio, including socioeconomic insecurity, international nurse migration, the impacts of economic restructuring on health systems worldwide, preventing hospital readmissions, and wearable technologies for weight loss, just to name a few of the projects that she works on. Dr. Van Eyck has worked for Group Health Hospital, Children's Hospital, the International Labor Organization, Public Services International, the California Nurses Association, Kaiser Permanente, and the Brown and Tolan Medical Group. She has expertise in quality improvement and utilization management, compliance, innovation, mixed methods and survey research, continuing education for RNs, and a variety of qualitative methodologies, including video ethnography, journey mapping, in-depth interviews, focus groups, and user experience research. And then last but certainly not least, Erin Hardesty is Senior Manager of Research Implementation, Culture and Equity in the Office of Research Patient Care Services here at Stanford Healthcare. In this role, Erin provides culture-related resources, coaching, and support to foster human-centered inclusion, diversity, and health equity, inclusive of all staff across Stanford Healthcare and Stanford Medicine. His prior experience includes healthcare innovation, experience in product design, and analytics consulting for healthcare systems and companies in the utility, retail, transportation, and entertainment industries. Erin's role here at Stanford Healthcare is at the intersection of his experience in organizational growth and governance, healthcare innovation, and community activism. He will help the health equity research team, as one of our newest members, identify and rapidly prototype initiatives to increase equity in clinical research processes and care delivery at Stanford. Welcome, colleagues. Thank you so much for being here. I'll turn it over to you, Dr. Williams.
Thank you so much, Dr. Mays, for your very gracious introductions of our team and for this opportunity to be here today to continue this important discussion on the past and future of race in medicine and research. My colleagues, Dr. Kim Van Eyck, Erin Hardesty, and I look forward to presenting A Time Towards Health Equity, which we believe will set the context for rich discussion today with those attending. And now, without further ado, I'd like to pass it on to my team members, Kim and Erin.
Thank you all so much. We'd like to start the presentation today by identifying some current examples of how race is used in medicine in the areas of medical research, patient care, and the medical workforce. Then we'll take a journey back through time at the beginning of this country's founding to understand how we arrived at our present state. And we'll wrap up by discussing where we are today and what our future could hold. Did you know that in 2019, Berkeley public health professor Ziad Obermeyer and a team of researchers at the University of Chicago found bias in a software algorithm that determined which patients got access to healthcare management programs for high-risk chronic diseases. The algorithm let healthier whites into the programs ahead of Blacks who were less healthy. They concluded that this racial bias in the algorithm influenced healthcare decisions for over 100 million Americans. Did you know that at the height of the pandemic, the pulse oximeter readings with race-based corrections overestimated arterial oxygen saturation levels for close to 2,000 Black and Latinx patients who would have otherwise qualified to receive life-saving COVID-19 therapy? Did you know that in a 2016 survey of 222 medical students and residents, about half endorsed false beliefs about biological differences between Blacks and whites? And those who did also perceived Blacks as feeling less pain than whites. They were also more likely to suggest inappropriate medical treatment for Black patients. Those medical students and residents with a higher than average level of false beliefs gave less accurate advice 15% of the time. How did we get here? Why have biological understandings of race and structural racism persisted throughout the history of medicine? Before we take off on this journey to discuss this, we want to provide a roadmap to navigate this complicated history and to understand how each historical period has shaped the use of race in medicine. While we see steady forward progress in the area of medical science and medical technology, the history of health disparities in our country is much more uneven. We'll look at events in history which illustrate the persistence of structural racism and the ways this has driven the development of inequitable social systems resulting in healthcare disparities. We'll be looking at ways in which racism was institutionalized through legal, economic, and political structures, which determined the kinds of systems that were put in place for housing, education, and healthcare, or what we understand now to be the social determinants of health. So this presentation will highlight these three trends. One, the persistence of structural racism over time. Two, the repeating patterns of legal, economic, and political policies and events that caused healthcare disparities to either rise or fall. And three, the progress and advances in medical technology and innovation. So we have one last word of encouragement for you before we undertake this historical journey. As medical historian Dr. Rana Hogarth states, quote, "Acquiring new medical knowledge and assessing healthcare are not as objective as people think, and historical beliefs about racial differences continue to cause problems in medical practice and scientific research," unquote. Racism in medicine is a problem with roots in the very foundation of this country. It's a history that has affected the health of Black, Indigenous, and people of color and the way they receive healthcare. Bias is deeply embedded in medical practices and has led to continued medical and scientific abuse and unethical experimentation. There are other moments in our history, however, when struggles to overcome structural racism and to improve the health of minoritized communities have made an impact. We hope that by sharing the stories of some of those who have gone before us to address racism in medicine, even in times of crisis, that you will find hope.
Thank you, Dr. Vanak. Between 1700 and 1900, we see the beginnings of race theory and vivid examples of the connections between economic systems and racism. We note medicine's roots in supporting the health of the plantation workforce. In 1790, Dr. Benjamin Rush diagnosed, quote, blackness as a, quote, particular kind of leprosy, unquote, naming blackness as a diseased state. In the 1800s, the goal of medical practice was to improve the efficiency of plantation labor and enhance control over enslaved peoples. In 1831, Nat Turner organizes a rebellion and destroys the white Southern myth that slaves were happy with their lives or too docile to undertake a violent rebellion. In 1847, the spirometer is invented and incorporates race-based corrections based on biological assumptions of smaller lung capacity for Black patients and Asian patients compared to their white counterparts. In 1857, Dr. J. Knott asserts that slaves are a biologically appropriate phenotype for hard labor. The intergenerational effects of hard labor can be seen today in a higher prevalence of asthma, maternal mortality, and high blood pressure among Black people in America. In 1867, Dr. Rebecca Cole becomes the first African-American woman doctor. She fought against the idea that diseases proliferated naturally in poor Black communities in her 30-year public health career. In 1876, the medical department of Central Tennessee College, which became Meharry Medical College, was the first medical school in the South for African Americans. These events highlight the response of minoritized communities to resist oppression and create opportunities to practice medicine in their own communities. A significant, yet not well-known figure was a midwife in the antebellum South.
67 years before Dr. Rebecca Cole became the first African-American female physician, the woman in this photo was born on a plantation in 1850. She was referred to as Big Cinda, and she was the great-great-grandmother of a Reverend Moses Berry. She worked as a midwife. The role of African-American midwives was a crucial one and involved not only caring for mothers and babies, but also and covertly for all the enslaved people on the plantation. Big Cinda was likely a very busy woman, as plantation owners viewed reproduction of enslaved peoples as essential to their continued wealth. Birthing more children than white women on average just increased the likelihood of Black mothers dying during childbirth. The belief that women of African descent could not feel pain in childbirth was commonly held by physicians and white enslavers alike. It was central to American slavery as it questioned the maternal connection between Black mothers and their children and justified the degradation of Black kinship within slavery. This story was part of the 1619 Project by Nicole Hannah-Jones.
In the 50 years between 1890 and 1940, legal efforts to segregate Blacks coincided with advancements in understanding social determinants of health as a major cause for health inequities, which continued to rise. In 1893, the Johns Hopkins Hospital and School of Medicine opened with rigidly segregated classes, hospitals, and medical staff. In 1899, W.E.B. Du Bois wrote about the social determinants of health, saying, quote, "Differences in health outcomes for Blacks and whites have more to do with living conditions than genetics," unquote. In 1910, the Flexner Report was published, characterizing Black medical schools as, quote unquote, underperforming. The subsequent closure of almost all Black institutions for medicine is felt today. This wide-reaching decision made it even more difficult for Black people in America to pursue a medical career and attend to community-focused medical care. In 1915, the movie titled The Birth of the Nation is released. It depicts Blacks as inferior and white KKK as a heroic force necessary to preserve American values, protect white women, and maintain white supremacy. This reinvigorated participation in the KKK in the United States, and at its peak in the mid-1920s, the organization's membership ranged from 3 to 8 million members. In 1916, the California State Board of Health monthly bulletin wrote about Mexican immigrants as, quote, "the type of people who are bringing typhus and other diseases into California from Mexico," unquote. This refrain is repeated today. Between 1915 and 1930, maternal mortality rates for non-white women increased by 11%. And in 1932, a 40-year experiment led by the US Public Health Service enrolled 600 poor Black sharecroppers in the Tuskegee study of untreated syphilis. In 1939, the AMA stopped listing African-American physicians as quote unquote colored. The Tuskegee study was a significant, though not isolated, example that reinforced an increasingly dangerous and longstanding distrust of the medical profession by people of color in the United States.
This is Herman Shaw. He was a patient in the infamous Tuskegee study. He was told that he was receiving treatment for syphilis. He never consented to an experiment. As was the practice in the 20th century, his body was used as, quote, anatomical material, unquote, for medical purposes. In 1997, President Clinton and Vice President Al Gore, during a news conference, apologized to Herman Shaw, who was then 94 years old, a Tuskegee syphilis study victim. This study appeared in the New York Times in an article with the title, "Bad Medicine, the Harm That Comes from Racism." A related story about medical experimentation without consent was also publicized recently. On the left is an image of Henrietta Lacks, and the photo on the right is of Oprah Winfrey, who played Deborah Lacks, Henrietta's daughter, in a movie based on the book The Immortal Life of Henrietta Lacks by Rebecca Skloot. In 1951, Rebecca Lacks was diagnosed with cancer, with cervical cancer. She was 31 years old. During her treatment, doctors took cells from her body and discovered they lived long lives and reproduced indefinitely in test tubes. These immortal HeLa cells have since contributed to over 10,000 medical patents aiding research. Her story is important, however, as these cells were taken without her permission, and neither she nor her family were consulted nor compensated for their ongoing use in research in decades to follow.
Post-World War II America was a model of technical, social, and regulatory advancement. Policymakers began to understand the impact of a race-based hierarchy and implemented changes intended to share the spoils of unprecedented economic growth. In 1953, the first randomized clinical trial was conducted and was originally designed to eschew bias in clinical research. Also in 1953, James Watson and Francis Crick recognized DNA as a three-dimensional double helix. DNA research accelerates. In 1965, President Lyndon B. Johnson established the Medicare and Medicaid programs, and in the same year, the Voting Rights Bill is passed to secure the right to vote for racial minorities throughout the country. In 1967, medical experimentation on Black and brown-bodied citizens continued. This time, Native American boarding school students were experimented on in a study on trachoma without their consent or the consent of their parents. Martin Luther King Jr. is assassinated in 1968, and the Black Panther Party begins offering free healthcare and other social programs, which end in 1971 after covert government operations dismantle the Panthers. In 1975, California doctors organize a month-long strike to protest rising insurance costs and inefficiencies in healthcare. And in 1977, the first magnetic resonance imaging, or MRI scanner, is tested. Many community activists today remember this tumultuous period when advancements were made in addressing race-based health inequities.
In the mid-1960s, Cleo Silvers joined the Black Panther Party as a healthcare volunteer. Free quality healthcare was one of the central tenets of the Black Panther Party. They set up their own free clinics, free ambulance programs, and launched the first national campaign for sickle cell anemia testing. The Panthers initiated a door-to-door testing program for diseases like TB and diabetes. Their legacy continues today with federally supported programs, including the free lunch program in schools, the free busing to prison programs, and free clinics. Years later, when the COVID-19 pandemic began, Cleo heard that Black people were dying at 3 times the rate of whites, and that this was caused by the social determinants of health. She said to herself, quote, "Ding, I've been here before, and it was 23 freaking years ago," unquote. She joined the Black Doctors COVID-19 consortium that tested more than 26,000 people.
In 1981, new economic policies were introduced, calling for drastic cuts to the public health sector, including layoffs in the workforce. In 1990, in contrast to these setbacks in policy and workforce, evidence-based medicine is introduced, encompassing clinical epidemiology to biomedical informatics. In 1984, the US Department of Health and Human Services releases a report noting major disparities in, quote, the burden of death and illness experienced by Blacks and other minority Americans as compared with the nation's population as a whole. In 2005, Doctors William and Sternthal found that African Americans and Native Americans have higher age-specific mortality rates than whites from birth all the way through to retirement years, underscoring the severity of healthcare disparities. In 2008, the AMA issues a public apology about past practices that excluded Black physicians. In 2009, Doctors William and Muhammad call for comprehensive approaches to health, including examinations of the fundamental social determinants of health, echoing the words of W.E.B. Du Bois. This period of history began with the privatization of healthcare, which exacerbated the divides between the rich and the poor. This period also included events that addressed health equity, healthcare disparities, and increased awareness of the social determinants of health.
The Affordable Care Act, formerly known as the Patient Protection and Affordable Care Act, and colloquially known as Obamacare, was a landmark US federal statute enacted by the 111th United States Congress and signed into law by President Barack Obama in 2010. Together with the Healthcare and Education Reconciliation Act, it represented the US healthcare system's most significant regulatory overhaul and expansion of coverage since the enactment of Medicare and Medicaid in 1965.
The years between 2013 and 2022 were the culmination of hundreds of years of systemic racism. In 2013, Black Lives Matter was founded as a direct response to Trayvon Martin's murder. In 2016, the survey we mentioned at the beginning of this journey revealed that about half of the 222 medical students and residents endorsed false beliefs about biological differences between Blacks and whites. In a 2018 study, Dr. Mary Feinling and colleagues found that 23% of the Native Americans had experienced discrimination in clinical encounters, and 15% avoided seeking health care for themselves or family members due to anticipated discrimination. In 2019, Dr. Olitha Maybank joins the American Medical Association as its first Chief Health Equity Officer, and we begin to see equity as a national health concern. 2020 brought the concepts of race and inequity to a global scale. Newly elected President Trump tweets about the, quote, Chinese virus, unquote, despite guidance from public health officials to avoid attaching race to a disease. From 2020 to 2021, reports of hate crimes against Asian Americans jumped 342%, and Black Lives Matter becomes a national movement after the murder of George Floyd. The AMA recognizes race as a social construct and not a biological one, and bias is found in fingertip pulse oximeters, delaying care for minoritized patients during the pandemic. In 2022, Dr. Moon Chen from UC Davis addressed our race-based reality when he wrote, quote, there's a conspicuous omission of Asian Americans in clinical trials. This is a reflection of institutional racism. Also in 2022, we begin to see, in response to the devastating impact of COVID-19, the resurgence of new variants, and most recently, the emergence of monkeypox. Race-based violence and structural racism have been identified as a public health crisis by the American Public Health Association, the CDC, and other leading healthcare organizations.
So here we are in 2022, looking ahead to 2023 and beyond. And the question is, what does it hold for us? The pioneers featured in this history of race in medicine have shown us the way forward. They've demonstrated courage in calling out unethical treatment, advocating for minoritized patients, and identifying and addressing health disparities and bias. Before we wrap up, we've got a few more inspirational individuals who provide us hope for the future. Dr. Paula Ross from the University of Michigan recommends that we do continue to use the terms race and ethnicity for the purpose of addressing healthcare disparities. She recommends that in our research, we provide a thorough interpretation of any disparities discovered beyond the simple reporting of statistical significance. Dr. Vanessa Grubbs, a nephrologist and associate professor at the UCSF School of Medicine, encountered the EGFR, or estimated glomerular filtration rate, bias while caring for one of her patients. She was quoted in the San Francisco Chronicle as saying, "I didn't think because he was Black that he necessarily had higher kidney function." She conducted additional tests without the race-based correction, and her patient qualified for a life-saving kidney transplant. Dr. Ruben Mesa of the Mays Center involved his community in resolving the disproportionately high rates of cancer in the Latinx population in San Antonio. They developed the Minority Accrual Plan, or MAP, which is a toolbox that has activities that are designed to educate, engage, and ultimately to increase diversity in clinical trials. Catherine D'Ignacio is the director of the Data and Feminism Lab. She's an assistant professor at MIT. Devona Bradford, also known as Zuni Pueblo, is a health educator at the Native American Community Academy. Catherine and Genova collaborate as board members of the Indigenous Women Rising. It's a group committed to honoring Native and Indigenous people's inherent right to equitable and culturally safe healthcare.
We have plenty of inspirational examples here at Stanford. Dr. Rafiq Bowen led the changes at Stanford Healthcare to replace the EGFR equation used with kidney patients and eliminate racial bias in the chemistry panels and point-of-care devices. In response to racial unrest throughout the United States, Stanford medicine leadership committed together that, quote, "We will not be silent. We will use our influence to affect change. Today, we say that enough is enough," unquote. These leaders made a meaningful and noticeable commitment to diversity, equity, and inclusion among the SHC population by supporting the BEAM team, a Black employee resource group. The Office of Research, Patient Care Services Health Equity Division will continue to build on Stanford's efforts to eliminate race-based health disparities. We'll be identifying and addressing health equity risks across clinical and research workflows, working to increase the diversity of clinical research participants, and offering consultation services for clinical researchers and practitioners for equity research and interventions. In the appendix of this presentation, you'll find tools, resources, and research to guide you on your journey. Please join us in this work.
Thank you, Dr. Van Eyck and Aaron, and thank you to our listeners. To summarize, we believe it's important for us to understand the past in order to intentionally and strategically plan for the future of health equity in medicine and medical research. We look forward to hearing your questions and comments. And once again, just thank you very much for joining us today.
A huge thank you to the three of you. That was incredibly enlightening and incredibly inspiring. You know, I certainly count the three of you among that list of individuals who inspire and also provide us all hope for the future. Thank you for the work that you do. You did a really successful, in my opinion, chronicle of over 400 years of racism and bias in healthcare. And I think it's fair to say that, you know, health disparities that we see today are far from new or surprising for that matter. And however, many of us are working in or interacting with organizations that are attempting to confront racism really for the first time, okay? And my question to the three of you is a little loaded. You know, are you optimistic? Okay, are you optimistic that we will truly move the needle this time on issues related to health, racial health disparities? And you know, what are you watching for? What signals would give you sort of increased optimism? And Aaron, can I go to you first?
What are the signals for increased optimism?
Yeah.
I think the formation of this group, this department, is a clear signal of increased optimism. Stanford Healthcare has shown, I believe you said, where the budget is, that's where the focus is. And if I could paraphrase you, there is leadership support and financial support for the focus on health equity, the division that we're working in. Additionally, working with a grant program for DEI and health equity initiatives to empower people internal to Stanford healthcare. That's just I hate to say it is the tip of the iceberg, but it's such a cliche, but it's true. I can defer to my colleagues because they have such a broad grasp of what we're going to be doing.
Thank you, Erin, and I'll just jump in really quickly. One of the signals that I've seen over the last year and a half, which is very inspiring, is the inclusion of health equity and DEI specific operational goals at Stanford Healthcare that we're working on daily, across 4 major domains: quality, safety, and we've added health equity. And we're interested in looking at disparities within the data across all data sets. Our goal is to first understand, and second, to look at ways in which we can make an impact to improve. Also, patient experience. My team is responsible for clinical trials operations and practice across care delivery. And we have, sort of front and center audience with our clinical researchers across Stanford University School of Medicine. So we can help by offering consultation when they are constructing their research protocols, also inspiring ways in which we can be more inclusive with communities of color in clinical research. And then also looking at our frontline teams across the organization, how might we provide education and support and guidance to understand the complexity of the communities that we provide care to. So these are just some signals of what I believe in looking back across my 30+ year career in nursing and healthcare, where we are interested in making an impact with our patients, with our staffs, with our communities. And just one last thing that I want to share with you, and a colleague of mine, Dr. Sunil Kripalani at Emory, I had the pleasure of having him join us about 10 years ago at Stanford, at Kaiser Permanente, for a talk that we were doing on medication adherence and looking specifically at communities of color. And, he kicked off his keynote by saying, we have over 3.5 decades of rigorous research on medication and treatment adherence. He said, it's time for us to take that knowledge off of the bench and make an impact. So that's what our team across Stanford Medicine is interested in, making an impact. So doing the research, but looking at ways in which we can incorporate it into our day-to-day operational practices so that we are making an impact. I'm really inspired by that.
Kim, I'm wondering if you can pick up on this point around translating science research to care, bench to bedside. You're a leader, you're all leaders in both research and clinical care. What is the call to action as it relates to intentionally focusing research in a way that advances and brings value to clinical outcomes, and closing some of those gaps that you all spoke so powerfully to, that Black and other minoritized communities have experienced for generations.
Yes, thank you, Terrence. I would just build on the comments that both of my colleagues have offered. The Health Equity Research Division team is very focused on what's going on in clinical trials. We have, as a part of our department, the Clinical Trials Division. So we're very closely partnered in this work of analyzing the degree to which there is diversity in our clinical trial participants. We have done a very preliminary study of the demographics, and we're already have plans to sit down and talk about changes that will be made in the coming weeks and months in that division with regards to capturing that data. So we're really ready and poised to make change as soon as we have the data we need. We know that there's willingness, and we're also positioned in this department alongside academic nursing research. So we're very interested in looping back any research that's conducted on health equity to nursing practice. So nurses on the floor every day, what are the opportunities to enhance their awareness of health disparities, to increase the degree to which their nursing practices are infused with considerations of health equity? And being here at Stanford and participating in meetings with RNs on issues of quality and compliance, I think there is a great willingness to also incorporate equity into those measures.
You know, Michelle, Dr. Van Eyck just mentioned the opportunity to engage nurses in this work. And, you know, there's some really good questions coming into the Q&A tool, and I'm going to get to those, but I want to ask you this one really quickly, because I was reading a recent article that said, according to Gallup, nursing ranked as the #1 most trusted profession for the 20th year in a row. Okay. And given this truly impressive position and trust that nurses hold within society, it seems to me that nurses are almost uniquely positioned to lead at the national and local levels on this issue on health equity, and perhaps it's already happening at some level. But Dr. Williams, can you speak to what you see as the opportunity here as it relates to nurses and health equity?
Certainly, and thank you for that question and comment, Dr. Mays. First, I'd just like to point out that if you look across the globe and across the United States at our professional nursing organizations, if you look specifically at their goals and intentions around health equity, they call out the role of the nurse and how critically important it is to address social injustices, to improve health equity, to be leaders and advocates in this area. Speaking specifically to the Gallup poll, first I want to just acknowledge nurses across the globe. You know, we have continued to stand in the gap as advocates for patients, for families, for our communities, and I applaud you. There are some key reasons why nurses are trusted, and I'll just call out a few. One, nurses care for the sick. We have seen this, we saw this through the COVID and continuing through the COVID pandemic with monkeypox and all of the things that have impacted people across time. Nurses have been there. Nurses ensure patients and families understand their diagnosis, their treatment, their discharge. You know, we're the ones at the bedside partnering with our physician partners and other clinical partners to make sure that the patient and their family understand what's happening with the patient and what needs to be done after that patient leaves the hospital. Nurses are empathetic. You know, we've heard that nurses are called to nursing, and I believe that. And I've seen that across my career, and I'm very proud of that. Nurses are dependable. You know, we've seen constantly across the news over the last 2.5 years in particular, that nurses are working, you know, double shifts. And, you know, not that we don't want to have to do that all the time, but really putting in the hard work to make sure that our patients receive care. We're partnering with our clinical partners across the organization. And then also, nurses are responsive. You know, we answer those call lights. We go into the room. We were there, you know, even when we didn't have all of the PPE, we were there. We wanted to make sure that we were at the bedside caring for the patients. That's our central focus. That's our value. And that's what we bring to our practice. So I applaud nursing across the globe again, because nurses are willing to stand in this gap on behalf of our patients and communities.
Yeah, nurses are truly heroes in our country and around the globe, to your point. I want to go to audience questions, and maybe I'll try to combine some of these the best that I can. One attendee asked about terminology, and they wanted to know, they said they've attended a workshop recently in which the speaker expressed that they did not like the phrase SDOH, okay, structural determinants of health. Because it perhaps has some hidden meanings that are not intended. They'd like to know if you have any thoughts on just the terminology, structural determinants of health. And then there was another question just around how do we embed learning and understanding around those social drivers of health and health outcomes within our curriculum and pedagogies for individuals studying to become health professionals. And anyone who wants to jump in.
Sure. Thank you, Terrence, and to the participant who offered that question. It's a very good one. And I think we are all in a constant state of learning with regards to equity language. We're currently undertaking a review of equity language guides that have been produced by health systems and healthcare organizations nationally. The AMA, for example, produced an excellent equity guide to narratives and language. We're hoping to produce something that can be distributed on the floor in hospitals and be readily accessible. I think it's important not just adopting the new terms, as the question is suggesting, that we also look at the reasons why we're adopting the terms, principally because they perpetuate notions of racism, which is doing harm to our patients when they're used. So we certainly want to avoid doing that. And the social determinants of health, there are various frameworks of health equity that use different terms. I think the word determinant is often questioned as suggesting that it's determined and there's no agency of those communities who are pressed to respond, which is a very good point.
Thank you. I want to try to get to a few more of these questions, but one question that came in, I think, is certainly timing and something that is on many of our minds and concerning many individuals. And that is related to the Supreme Court reversal of Roe v. Wade. And in particular, the subsequent abortion restriction laws in many states, as this attendee writes, that would appear to disproportionately restrict the access to full spectrum reproductive health care for minority and lower income women. Do you have any comments on this issue?
I will begin. We are very interested. We will continue to, for the term, for now, we'll use social determinants of health as our framework. We are very interested in moving as upstream as we can in the social determinants of health. One of the areas that I've been interested in is food insecurity, the agency that one gets by addressing food deserts with cooking classes. Further upstream would be addressing the disparities between maternal mortality rates. It is statistically more dangerous to have a child if you are a Black woman in America. The reasons for that are myriad, and specifically Roe v. Wade exacerbates that reality. It makes it even more dangerous to be a pregnant Black woman in America. That is my perspective. The degree to which we will address that is, I will defer to the director and executive director, but it is statistically more dangerous now to be a Black woman pregnant in America because of the reversal of Roe v. Wade.
Anything to add, director or executive director?
Well, I would just say that we can rely on nurses and other activists and advocates for health equity to step up and to fill that space as they have done throughout history. And we would aspire to join with them and partner with them in that work.
Mhm.
And I'll just add that we're also partnering very closely with our Stanford Children's Hospital, where we have maternity and children's services, to look at ways in which we can sort of support their research and their work addressing the implications of Roe v. Wade, particularly with the lens that we're using, which is health equity. So, more to come there. We're still sort of sifting through all of the information that's coming out and looking at, sort of where this will land from a sort of a policy and political standpoint. So more to come there. Thank you for the question.
I want to get to Jonathan's question in chat in the Q&A, because the three of you are leaders in this space, and you have a platform in which to effect change. Some of us, depending on where we sit in the organization, may not feel like we have that same level of authority or agency. And Jonathan's question is, what are immediate actions that individuals within our organizations can take to contribute to combating racial bias in medicine in their daily practice and daily work?
I'll just sort of kick this off by saying, first, thank you for the question. It's a really good question. I would say awareness and, creating forums where, frontline staff and colleagues across the organization can get together and talk about it. When we started this conversation very intentionally last year, I will tell you that I've heard more across the organization in the last year about health equity, concerns about equity, disparities than I can say I've heard across my entire career. So I think just starting the conversation at every level. One of the things that we have done at Stanford Healthcare is we've presented some of our research at our shared governance council meetings. We're continuing to do this just to raise awareness among our frontline clinicians across the organization. We're having lunch and learns. We're talking about it in our, and we'll be talking about it more in journal clubs and so forth. And tomorrow, on Friday, we're launching a seed grant program across the entire organization for frontline teams to, have an opportunity to get funding for their ideas, research, and practice changes around health equity and DEI concerns that they're seeing either, in their practices or that they're hearing about. So I think start the conversation at every level in the organization, and you'll be surprised where that takes people. Thank you.
Please go ahead, Kim. Please go ahead.
I was just going to add to that I have heard of nursing units where they are at each morning huddle, they're including one word or term that they are attempting to change in their language with patients. So that's inspiring, one word a day to look at that. And our website also will feature a lot of tools that have been used nationally to toolkits, ways to engage with patients and healthcare providers. There are courses available, even in the PowerPoint deck from today. There are bias reporting tools and health equity measurement frameworks that we can examine and Stanfordize, if you will, here, and other folks can do the same in their own healthcare systems. So there's a lot of information, a lot of practical hands-on tools that people can look at incorporating today.
Yeah, and it's about utilizing and sharing those tools. You know, Sherilyn in the Q&A says, Stanford is obviously the leader in addressing healthcare education disparities now. I might contend with that a little bit. I think we are a work in progress. However, you know, the question says, I'm wondering how long it will take other institutions of higher learning to demonstrate competence in the proposed areas. Any thoughts on that? You know, I will say for myself, I'm hoping it won't take us 400 more years to make progress here. But any sense from the three of you in terms of how long it will take to really move the needle?
So I'll start. I agree. I don't think it's going to take another 400 years. There is a national conversation underway. The American Hospital Association is currently trekking across the United States, meeting regionally across 9 regions and engaging healthcare systems in this conversation. And what we found through an environmental scan looking across the United States at healthcare systems, this was led by our colleague, Dr. Monique Lambert, an environmental scan, we found that a lot of healthcare organizations are moving this needle. So we're really happy to see that. And I just think one of the things that we can do as individual, professionals in the healthcare space is take a stand, start the conversation. Look and see what's out there in terms of, seed funding that you can utilize in order to do small tests of change in your respective organization. We started small, it was just a 30-minute conversation last year with our chief executive officer, David Entwistle. We started talking about things that we really wanted to do, and it just grew from there. So I think you can start small and grow big very quickly. I think you'll find that people are very interested in moving this forward. The other thing that we did that I think was really exciting, and Aaron is leading this work across our organization with a team, is we introduced design thinking within our Stanford healthcare care delivery setting, specifically with our Black employees, to understand from their perspectives, what it's like working in an academic medical center for them, what their experiences have been and observations have been with regard to patient care, and what are the opportunities for us to make an impact. We are moving forward on a lot of the ideas that came out of that work and hope to publish this year and next year. And also we invite you to follow up with us. We'd love to hear from you. We'd love to talk to you. We'd love to hear your ideas. We have not thought of everything, of course. And we know that there's so much that we can learn from the experts across the globe.
Well, and I think that is a great way to wrap this conversation. And thank you, by the way, for mentioning design thinking, because I think that offers a really useful framework for thinking about health equity. This has been a truly, truly enlightening and moving discussion and very practical tips that you all provided. So thank you. Thank you for the call to action. Thank you for your leadership. With that, I'd like to pass it over to my colleague, Dr. Daryl Oakes, to close us out.
Thank you. I just first of all have to just thank you, Dr. Williams, Dr. Venek, and Aaron. I mean, that was just such an informative, powerful, and really sobering presentation, and really a powerful discussion. So thank you. I really appreciate your leadership in this area, and the work that you're doing is so important, and I think highlighted by all of the different historical context you provide. And also we're obviously in a new moment. Every month and year seems to bring new poignancy to these conversations. So thank you. And again, just for the audience, I'm Daryl Oakes, and I'm an anesthesiologist by my clinical work, but I am the Associate Dean for Postgraduate Medical Education, and I lead the CME office in that role. And I just, on behalf of the core consortium of the Stanford CME office and the Office of the Faculty Development and Diversity and the Stanford Medicine Reach Initiative. We really just want to thank all of you for attending, providing your questions and engagement in this program as well as the series, and really hope that you will join us for our future presentations as well. If you are interested in claiming credit, just please look out for an email today. It will have a link to an evaluation, and when you've completed the evaluation, you'll be able to claim your credits. And we will also, for those of you who only were able to catch some of this, or for colleagues who were not able to attend, there will be a recording of this webinar available on our website, and it's under healthequity.stanford.edu. And so please look out for that. And again, thank you to the Stanford CME team, Kurt, Melissa, and Jazona, who do all of the work in the background to help make these programs occur, and to my co-course directors, Terrence and Magali, again, for helping organize our speakers and our programs. So again, this is a pretty exciting program that I've been so happy that we can partner to make happen. So again, maybe please check in. We will be having our next session August 18th, Thursday, August 18th, from 11 to 12 again. And again, hopefully we will see you all back then. So thank you.
Thank you.
Thank you.